and hepatology. And I would like to give everybody, please give a round of applause for this fantastic gentleman right here. Thank you.
Thank you. Hello. Can you all hear me okay? Yes. Good, thank you. Welcome all to Cleveland. I'm a pediatric hepatologist, so I try to make sure that it didn't sound like a herpetologist, which will be different than so I also manage metabolic disease, including GSDs, and that's my background. So that's my disclaimer. And welcome you all to Cleveland. My journey over the years has taken me from India to the southernmost part of India, which is a beautiful place I can see. It's a lot of backwaters. And then on the mountain side, within 70 miles, you can get the mountains on the other side. Well, just what you're seeing is a tea plantation. Took me to the UK. I was at the University of Leicester for about 4 years. Then I ended up in Cleveland. And what I learned over these years is that I had great many teachers. Teachers who taught me medicine, but my best teachers over the years have been you guys, the patients. You taught me to be empathetic, enticed me to read more, research more, and be a better physician. And on top of that, I honed my clinical skills on many patients, the many livers I felt, the many spleens I felt. And every time I felt even better that I can diagnose one sooner. So thank you all for being here. Cleveland is a great place. It was formed in 1976 by Moses Cleveland, who was a United States surveyor. So it's Cleveland that Moses Cleveland is spelled different, as you can see. But Cleveland is a hometown of Rockefeller, for people who know that, who built his fortune in Standard Oil. The Standard Oil then became Exxon and many other oil companies over the years. The Millionaires Avenue, which is the road that grows in front of the Cleveland Clinic, housed almost 250 millionaires. So when Chicago was still not a big city as it was, Cleveland was the place. And it's the origin of Superman. How many people knew that? Just 2 people. 1 people. 1 person. 2 people. Okay. So so if you look at the Superman cartoons, the pictures, the skyline is actually the Cleveland Clinic skyline they draw in the background. Cleveland is famous for starting EPA. So the river on fire, so the Cuyahoga River catches fire. It's water catching fire, no, not really, but it's caught fire almost a dozen times. In 1969, the last time, it sparked the environmental movement to start the EPA by President Nixon. But the Northeast Ohio was, while the big trees in Michigan was picking up steam, was a big car hub. Almost 100 car companies. And you can see the remnants of that if you visit the Museum of the Western Reserve in the Cleveland Case Western Reserve University. And then the Theater Place District is one of the second largest in New York. And the Cleveland Orchestra is one of the big 5s in the United States. So it's a lot of good history. I could go on and on and on. I will not. But Cleveland also has a lot of historic facts to talk about. It's a birthplace of Harvey Cushing. How many people know Harvey Cushing? 1 person? 2 people? So he was the father of modern neurosurgery. So he went to Italy and met River Rocky and brought a sphygmomanometer, which is the art of the time to check blood pressure. And though he was not the inventor of sphygmomanometer, he kind of made it better. But it's also the discoverer of serotonin, Dr. Irving Page, was the first head of Cleveland Clinic research. Unfortunately, the man never got a Nobel Prize, probably because it cannot be given posthumously. But also, Cleveland Clinic did the first coronary catheterization. So it's come to serendipity. So in olden days, they would use these sort of catheters. And the reason was, he was a pediatric cardiologist, by the way. And he was doing cath, and he was injecting the aorta, the big vessel that takes off on the heart. And the catheter actually accidentally went into the coronary artery. So when that happens, well, people who know physiology, it triggers a reflex called Besor-Jarich reflex. The heart's kind of stopped. And he asked the patient to do a Valsalva, and the heart restarted back. And now many, many millions of coronary catheterizations since then. But one simple serendipity led to that. But if you look at the history of cart cath, it was actually done by a medical student who self-catheterized himself through his cubital fossa in Germany in 1938, put a catheter all the way through the heart, took a picture himself, and said, oh, I can put a catheter into the heart. And then the first coronary bypass, well, sort of, was done in the Cleveland Clinic by Dr. Rene Favellaro. There's a physician from Argentina here who's Damien, right? Did I say it right? Yeah. So there you go. The father of, well, the first coronary shunting cath was not actually done by a physician in New York and connected the internal mammary artery to the coronary artery. But Northeast Ohio employs a ton of people in healthcare. And so it's kind of one of the highest employment area in this part of the country. And so from that perspective, I'm going to talk about why I was asked to talk, which is pathology of the GSD. Come back to reality now. So my perspective is no different than any of the wonderful geneticists and others up here. I treat them like you guys do. But talking about the liver. So the liver is in the right upper part of your body. And it's got two parts, the left lobe and the right lobe, as you can see. The left lobe is a little smaller. And looking at it from the back, you can see the gallbladder. I will not go into the details of all this. But then, for the surgical purpose, when a liver surgeon operates on the liver, he looks at all these sort of 8 zones. It's called the Cohen-Nenad segments. Remember it? And forget it if you don't want to. And then, this is the liver at a microscopic level. So I cannot talk histology without telling you what the normal is. So on the top, you see is the central vein. And then here, the other blue is the portal vein. The portal vein drains the intestine into the liver and then divides into tinier branches. So the blood from the portal vein drains through the liver cells. It's a perfusion system into the central vein. And then the liver cells start making bile, the green pigment that liver excretes out. It's got a lot of good stuff in it and maybe some not so good stuff in it. The green color is from bilirubin. It also calls bile salts, which is important to digest and absorb fat. There are different types of bile salt for another time. And this microscopic histology is a liver cell. It's the blood that flows around it, and then the stuff perfuses into the liver and back, and that's how it works. So the liver has about 500,000 lobules, and each lobule has hundreds of cells. So the liver is full of billions of cells, and each liver cell lasts about 300 days. In one of the meetings, somebody asked me where is the reference, and I had the reference, I couldn't find it, but I did find it. So it's about 300 days, and the good thing is that each time the liver cell dies, its liver dies with a process called apoptosis. It's a programmed death, and releases some liver enzyme into the blood. The good thing is that we can use that to monitor whether the liver is functioning well or not, in simplistic terms to say it. At a histological level, liver is made up of many little honeycombs, called the lobules. And as you can see, the blood flows from the portal region into the central vein and then back to the heart. And then if you look at it on a closer level, this is the central vein, and this is the portal triad. When you say triad, it has got a portal vein, an artery, and a bile duct in that, which is why you call it a triad. Forget the zones, it's called the Rappaport zones for the metabolic people. The same Rappaport who described the Rappaport-Lubering shunt that is important for oxygenation in the red cells. Now, at a microscopic level, when you look at the liver, which I talked about the portal triad, it's a portal vein in the middle. The thicker one is the hepatic artery, and down here is a bile duct. So this is kind of what the liver is at baseline made of. Around is the liver cells. And if you look at it at a closer level, each liver cell stains pink, eosin, and the blue is hematoxylin. And the liver cells, the nuclei are in the middle of the cell, and a fairly distributed cytoplasm around it. Now, just to remind you that this is a talk on GSD, when I started training in 1985, I was told there were 8 types of GSD. Now it's kind of broadened out to about 15 types, and maybe more coming down the road. And this is just to remind you that that's nothing more than that. GSD1 is one of the severe types we follow and manage. And it's due to the mutation enzyme called glucose 6-phosphatase, and a lot of you guys know that already. And now this is a slide, let's show you that I have some slide making skills. I try to put this slide together, say GSD1A and GSD1B, sorry. Two different disorders with similar phenotype. Now coming to the histology, histopathology in GSD, this looks kind of like a blue color, but if you look at it, this looks very coarse. This is a biopsy of a patient with GSD type 6, which is hepatic phosphorylase enzyme. And if you look at it more carefully, can you see this coarse look? It looks like there are a lot of lumps clumped in the middle. And then you look at it closer. You can see that there are cells with lighter color and blue colors, and the nuclei kind of shifted to the sides. You've got to trust me on this. And then, so the liver cells look enlarged, engorged, with this eosinophilic or pink-colored granular material. When you stain these cells with a chemical called PAS, it stains really like magenta. That tells you two things. Either there is glycogen, or there is something called alpha-1 antitrypsin. Now, so to prove it's glycogen, they stain it with a digesting enzyme called diastase, which is a starch digesting enzyme, and all the color then goes away. Is that good thus far? Good? Very good, thank you. So now with GSDs, some of the types can develop scarring over time. It includes GSD 3, 6, 9, 5, 4, and not 4, 3, 6, 4, and 10. 9, sorry, beg your pardon. I'm completely confusing you guys. 4 types. But we don't have a good idea about the longitudinal monitoring of these patients. We need a lot of studies and outcome out there. But that I've seen patients develop cirrhosis and portal hypertension. When you talk about scarring of the liver, we use a stain called trichrome. It stains it blue. So you can see this is the portal tri. Remember the area with the portal vein and the hepatic artery and the bile duct. So we like to stage them, and there are different types of staging systems used. One I kind of quote here is the BAT and the Ludwig system. So this is stage 1, which is the periportal corner area starts to have some blue color, which is suggesting that there's some scarring in there. And then you look at the periportal area, and this is the hepatic lobule. The scarring is starting to enter into the lobule, from here into the lobule. This is stage 2. And stage 3 is the lobules start to connect to each other. Scarring is starting to connect from one lobule to the other. So it's kind of bridging fibrosis, as we call it. And then last but not the least, the scars are engulfing the lobules, and the liver is starting to regenerate in a haphazard way. That is stage 4 or cirrhosis. Now, to put it in perspective again, this is a biopsy of one of my patients. So he showed up to me many years ago as having autoimmune hepatitis. Liver was significantly enlarged. Didn't make sense it was autoimmune. So the biopsy kind of looks kind of a little pale blue, pink in overall. And look at it under the microscope. You can see that the liver cells are all engorged. The nuclei is starting to push to the side here a couple of times. A lot of cells engorged up. And then you see that the staining, again, the PAS staining with magenta and the diastase, and it all goes away, right? So when you stain this patient's liver biopsy with trichrome, you can start to see that it's starting to bridge. So it's a 5-year-old, and so fibrosis can happen early, and these patients need close monitoring from that perspective. Now, we like to do biopsies, but biopsy probably is not as simple and easy to do. So we look at serological markers, and there are a lot of markers out there. I put some of them out, like APRI, FIB4, liver risk scores, and all that stuff. And again, these are a lot of semantics and acronyms, in fact. And this is the point of this, is to say we can use liver numbers to look at some predictors of advancement of fibrosis. However, if you see someone with an abnormal number, we need more testing to figure out the degree. So some of them are indirect markers, which means that you are using the blood tests that we have in hand to kind of extrapolate to predict the risk of fibrosis. It doesn't prove that there is fibrosis. The gold standard obviously has to be biopsies and stuff. Now, there are direct tests. So when you have scarring in the liver, there are certain chemicals that get activated or enzymes that get suppressed or activated. And so these direct tests, especially the enhanced liver fibrosis test, is widely used in liver practice. So there are many, many more. The point is there are these tests. But then you can also look at the liver and look at ultrasound. I look at the liver like a sponge. If you take your sponge and you dip it in a little bit of clay and you put it to the side, you can squish it, but it's more crumbly, a little more stiffer. You take this liver, a sponge, and you dip it in liquid mortar or cement, dry it up, the liver gets really hard. So if you look at scarring, you look at sponge in clay, sponge in mortar. So the one in mortar is the hardest cirrhotic liver. The other one is fibrosis. Does that make sense? So you can look at it in that way. So what does the ultrasound do? So ultrasound looks to see if the liver is squishable or not squishable, and how squishable it is. So they send these sort of waves into the liver, and if it's a solid liver, the waves travel quicker. If it's not so solid, it'll travel slower, and you can extrapolate that to predict the risk of fibrosis from there. So LSM is a liver stiffness measurement. It's measured in kPa, kilopascals. And the caveat is that there are different cutoffs for different diseases, and we don't have good standards for GSDs as such. But we when I see a patient, let's say the numbers are normal, and in 2 years it starts to go up. I used to use that to longitudinally monitor. The numbers start getting more tougher, or higher. Then I monitor that patient more closely. It's a sign that you need to keep a closer eye on that liver. So we have the most bedside use test called the vibration control transient elastography, in common terms called elastography. But then there are ultrasound machines. So this can be done at the bedside. You don't have to be trained in doing an ultrasound, particularly to do this test. But then the acoustic radiation force impulse is an ultrasound where the elastography is embedded in the ultrasound probe, so the radiologist can do the dual test for you guys. So you can measure the velocity of propagation of the sound waves through the liver, and then extrapolate it to make it into kilopascals as well. And then there is a point shear wave elastography where the ultrasound wave itself is used to kind of monitor the stiffness. And last but not the least is probably even a better test called magnetic resonance elastography, where you try to shake the liver with magnetic waves to look at how stiff the liver is. So all these tests are out there. And when you look at these tests, this is how some of them look. So this is the elastography. So basically you send this is the one I'm trying to highlight. There's 2 ribs and the space between the ribs. So for a good test, you will see that the line goes in parallel to the rib, and you know that then the study is good, at least from the observer's perspective. And so it gives you 2 numbers. It gives you the kilopascals, so the stiffness number, and the CAP score. And this is basically look at what is in the cell. So the high CAP score suggests there could be fat or glycogen in the liver. And then this is the pulse wave, where you can actually topographically look at the liver and see where you're looking at, where the fibrosis is. And last but not least, this is the RV test. Same thing using the ultrasound wave. But last but not least is the MRI. It gives you a more topographic representation of the stiffness. A high number, the red one, suggests there are scarry areas more than blue, which is kind of lighter, if that makes sense. Now, these tests have advantages and disadvantages. See, the advantages is that it's easily reproducible. It's a bedside test and all that. I'm sorry, this slide is not projecting well. The disadvantage is that it needs equipment, it needs skill sets still, and if you have borderline numbers, they may not truly represent what the degree of fibrosis is. If the number is very high, you can say that patient has cirrhosis. If the number is normal, you can say that's good. But in between, prediction is not very good. So probably in that context, you need a liver biopsy. Now, when I see GSD patients, and many of my colleagues in the room who follows patients and patients by themselves, there is a risk of hepatic adenomas, particularly in GSD 1 and 3. And the risk goes up with age. So adenomas are collections of liver cells where the histology is altered, and I'll come back to that. It's a higher propensity for females to develop adenomas in general, and that's a rule of thumb even outside the GSD spectrum. And sometimes these adenomas can get really big and they can bleed. And there are situations it can cause anemia because of the degree of bleeding. Now, and usually we pick them up on ultrasound, brings a point of doing serial ultrasounds and imaging on these patients. Now, when you look at these patients, there is good suggestion that if your metabolic control is not as wonderful, the risk of adenoma goes up. That said, even with some of the best metabolic control, some patients do develop adenomas. The pathogenesis of adenoma is really complex, and I'll probably next slide highlight that in a second. So when I started to train, there was just hepatic adenomas, right? That's how science goes. And then they said there are 3 types of adenomas, right? There is inflammatory type, hepatic nuclear factor 1 beta mutated. And this particular gene is interesting for all the endocrinologists because mutation of this particular gene from a genetic germline perspective causes a disease called maturity onset diabetes of young type 5. And then there's this gene called beta-catenin, which is important in cell cycling. And mutations in exon 3 particularly is high risk of developing hepatic dysplasia and hepatocellular carcinoma. And mutations in exon 7/8 has a high risk of large adenomas with risk of bleeding. And then this classification started getting even more. So it's into unclassified type, sonic hedgehog type. These are basically germline mutation, somatic mutation, not germline, meaning you're not born with it. It happens in the tissue. And then I started reading about adenomas in the setting of androgen therapies and pigmentary type, myxomatous types. And so there are so many different types of adenomas as time goes by. Science is expanding. Now in GSD type 1 in particular, you find 3 types of adenomas. The most common type is the inflammatory type. If you look at these adenomas, the genes are involved in the JAK-STAT signaling, which is an inflammatory signaling cascade. JAK inhibitors are out there for treating many other diseases now. So to downregulate inflammation and improve healing. So these genes implicate STAT3, GNAS, and IL-6 are all pro-inflammatory pathways, if you may. And about a quarter of these patients do develop beta-catenin mutations and have a high risk to develop hepatocellular carcinoma. And the 20% are, I don't know what it is, it's unclassified type. Am I going too fast? No. Am I confusing you enough? No. Okay. So this is when you look at an ultrasound, this is what the adenoma looks like. It looks like the liver ultrasound looks at shades of, this is for the patients and not for any of my medical colleagues, looks at shades of gray, white, and dark, right? So, so the liver has kind of this slightly white color. Too much white is not good. And when the ultrasoundologist looks at the whiteness of the liver, they're looking at the cortex of the kidney to compare it. Now, I think I'm good at reading. I look at all the ultrasounds myself, not that I don't trust the radiologist. I had to see it with my own eyes. So my colleagues who work with me know that. So if you look at this ultrasound, this white thing is your breathing muscle, the diaphragm. This shadow that looks a little different, less white, is an adenoma. And you can look at it, there is a ring of clearness around it. So it's called an atoll sign, like an atoll in the sea. So there is a hyperechoic, a whiter mass with a little bit of clarity around it. And this is a 38-year-old patient. And then if you image this more carefully or with an MRI, whenever you see an adenoma, if you want to know what kind of adenoma you want to qualify it better, you do an MRI. So this MRI, if you look at an MRI, there'll be like almost 40 different sequences. And you got to have the patients to read it. And so it might take you a good 10 minutes, at least to look at an MRI carefully. So there are different types of MRI images. So in an MRI, basically your body is subjected to a high magnetic field, And in that field, your hydrogen dipoles, which is part of your water molecule, align themselves like this. And then in MRI, it's hit with a radio frequency wave to swing it to 90 degrees, T1 weighted image. And they look at the time it takes for the dipole to return to about 2/3 its basic state, that is T1. And in T2, it is hit with a radio frequency wave to make it turn 180 degrees. And they look at the time it takes to return back to 2/3 its state. A lot of jargon, but then they use a computer model to generate images, and that's how we generate MRI images. I don't want to sound like a radiologist, but little things I learned in medical school, I'm sharing. So here in this patient, you have a T2 weighted image. It's fat suppressed. They can use different combinations. You can start seeing there's a difference in color. The white arrow points to that. And then in here, it is a specific dye used. And the image, and it's a late image. So, and the important is this relevant. It still shows it white. If it's a hypermetabolic lesion, means it's something starting to turn malignant, then blood flows in quickly and flows out quickly. So when you do a late image, it will be almost the same color as the liver. So this is a good thing that is retaining some contrast late into the image. Now, and then you can sometimes see bleed. So this is a T1Y image, not to get into details. You can see a patient having a big lesion in the middle that is not lighting up much. And also, this is a late image showing the same thing. So a patient who had a big adenoma that bled, but he's doing well. So if you look at adenoma under the microscope, coming back to what I was supposed to talk about, histology. So this is a patient with GSD1A, was a late diagnosis into his 40s. Showed up and was noted to have a big liver. So here you have the portal vein, the vein that drains from the intestine into the liver. The liver cells are all like engorged. You can see at a closer view. The nucleus, some of them are pushed to the side, and it's filled with this amorphous pink staining material. And then you look at this one. This is the biopsy of an adenoma. Compared to the left one, the right looks more crowded. Would you agree with me on that? Okay, thank you. And so, if you look at it even more carefully, you got to trust me on this. The nucleoli and the nucleus looks kind of different. It's starting to show some irregular features, which call it atypia. It's starting to act different. And then in this same patient, when you look at another area, that starts showing, even the nucleus is showing more atypical features, suggesting this is early hepatocellular carcinoma. So the nucleus is all looking irregular and different, and if there is per each cell, compared to the other cells I show where the liver is full of glycogen, the liver starts to shed glycogen. There is more nucleus compared to the size of the cell. So the ratio changes. And then they stain it there are so many different stains you can use. I did pick this particular stain to highlight this. When you stain it with glutamine synthase to look at metabolic activity, this is the hepatocellular carcinoma side. Looks much browner than an adenoma side, which is less browner, right? So there are different ways you can stain these, but to give you an example of it. So when I see a patient with GSD1, and all the GSDs for that matter, we need to look at the liver more carefully. So we monitor the ultrasounds yearly to every 2 years, even more frequently if needed. And then when they start getting older, we start thinking of MRIs, in particular if the ultrasound shows abnormality. This is in relation, along with all the labs we do every 3 months or 6 months based on the patient's needs. And that's my slide, end of my talk. Thank you so much. I'm on time. I was asked to talk for 30 minutes.
Okay.
There you go. I did it.
Excellent. Since we have a little extra time, does anybody have any questions? I mean, what I got out of that is squishy, spongy liver. Crunchy.
That was good though, right?
Right? That was
good.
amazing.
Yeah,
That was amazing how one's able to bring such a complex subject matter into something that we can all visualize with regards to the liver. Does anybody have any questions for the doctor? Any questions right here? Questions? You got a question? Okay, let's do it. Here you go.
Thank you. That was wonderful. Yes, I'm Rebecca Reba-Wolbin. I'm an endocrinologist in Connecticut. That was really wonderful. I will have even more questions, but I'll start with just two. Are there benefits of the RFI, or I don't know the correct pronunciation, RFI or RFI or VCTE, the bedside? Kind of what additional information do you feel like it's significant enough to do that with the machine?
So the elastography machine, I could train myself to do it. I don't have to be a radiologist to do it. Mm-hmm. So that's the advantage of a bedside test. But if I want to get a good look at the liver in general, if you follow in a GSD1, I started doing ordering the combination test. The patient goes one-stop shop, and you get the ultrasound and elastography with one visit. Otherwise, I had to send the patient to one person because to do the elastography and an ultrasound with the other person. But it also, again, gives me a good idea of adenomas and everything else. So I've kind of moved away, and Beth, who works with me, I have a wonderful team I work with, Elizabeth Robinson and Christina Calling, a GSD team from Cleveland. So we kind of moved our practice doing that more and more.
I'll ask one other question. So GSD1, we have the most information on, but other GSD types develop hepatic adenomas. Do we know anything? Are the somatic mutations, are the adenoma types similar? Is that known?
The GSD3s?
Others, so GSD3 and sometimes GSD9, correct?
Yes, and then 6 too. Yeah. And so I think if I say I could give you the little I know is probably more inflammatory type, that the beta-catenin mutated types. But we need more information on it. But the important thing I want to highlight is that if you have good metabolic control, you can certainly reduce the risk of adenomas. And in GSD 3s, 6s, and 9s, you can also reduce the risk of long-term scarring as well. So I think metabolic control is important. When I started to train, I was told, see GSD9, see it, forget it, don't bring them back again. It's not the truth. We have to follow them closely. And I think I've talked to David Weinstein in the past as well. We are on the same page that these patients need monitoring longitudinally. So, but Dr. Wolman is the head of our AGSD Scientific Advisory Board now. So there you go. Yeah.
Thank you for your talk. A little bit related to your last comment. For patients that demonstrate changes related to fibrosis in the liver and metabolic control is already optimized, are there any current measures or measures that may be under development to prevent progression of fibrosis?
That's a very good question. So, I can only talk from a fatty liver perspective. There are newer treatments out there to kind of slow the rate of scarring down. And not only just from a liver perspective, but there is a lot of anti-fibrotic or anti-scarring treatments in other diseases being looked at for example, inflammatory bowel disease as well. But I don't know whether it's right to say that we can extrapolate that into GSD, but I think over time, yes, with research and trials and outcomes, yes. That was a very good question. Thank you.
Jim Ryan, parent of Nayland, who has type 11. Have you worked with type 11s, and if not, anyway, what are you usually seeing on liver imaging? And you had mentioned a separate question. You had mentioned about at a certain age, we should move into MRI imaging?
Yeah.
And what age range would that be?
So this is what let's say I see a 7-year-old, but thanks for the question though. I've not seen a type 11, I know what it is. Let's say I see a 8-year-old GSD1, and I see that the liver has a couple of funny looking shadows. In that patient, I will get an MRI to define the lesion better. If I know it is an adenoma, and I can correlate that with the ultrasound, because to get an MRI in a 7, 8-year-old, I'll be thoughtful because the patient may not lie still. So if the GSD1 patient, I have to bring them overnight, admit them, keep them fasting, get them anesthesia and stuff. So it takes 2-3 days for that process to work out, right? Now, so if the ultrasound and the MRI correlates, and the adenoma is not increasing in size in general, the adenoma looks benign, which is mostly likely at that age, then I can use ultrasound to serially monitor it. That's my practice. Now, on the contrary, like say the next year, patient is 9 years old, and the adenoma looks even bigger, then I get another MRI, because I want to make sure that the adenoma, obviously I'm going to look at the metabolic control and stuff on one side, but on the other side, if the adenoma looks bigger, I want to define it better, to see if it's any funny flow pattern, is it washing out quickly, those kind of things. Did I answer your question?
Although you had said you haven't seen an 11, are adenomas present with that type, or are they seen with that type?
I don't know. I don't know there is good longitudinal outcome data, but I can do. David, yes, yeah. Yeah.
There are just, I think there is a report of a patient with Fanconi-Bickel that developed
Oh,
adenoma.
sorry, you're absolutely right. No, to clarify, with Fanconi-Bickel, there is an inherent risk of liver dysplasia, or funny changes in the liver. Does that correlate with adenoma is not clear to say. So now I thank you for clarifying. My mind went into a blank thing for a second. So if you look at genetic disorders that has a higher risk for hepatic dysplasia, meaning abnormality, this is one of them. But we don't know whether all of them correlates with an adenoma before it develops into dysplasia or not. Something I don't know the answer to.
Thank you very much. Are there any other questions in the room here? As we do a clean sweep. Oh, one more right here. Awesome. Last one for right now. Here we go.
My name is Jennifer. I'm a parent of a GSD type 3A. And I am wondering, everyone throws around the term good metabolic control, or can you define it in your practice?
That's an excellent question. So I think the best metabolic control if someone doesn't have GSD. Right, so you have to be practical in the way you look at it. If someone is saying that you have GSD1 and your triglyceride, you won't expect it to be 100. It's not going to happen. Now, that said, we follow about 16 patients in the Amish region. There's a slightly different mutation, if you may. And I've had patients with excellent triglycerides, excellent uric acid. So there's a subset that's possible, but I look at what is relatively achievable. So if I ever see a patient and I see that the lactic acid is 7 on the short term, 8 on the short term, I know that is not good on the short term, right? They're getting too many hypoglycemic episodes. On the long term, the triglycerides are like 500. The next time I see them is 600. The next time I see them is 1,000. I know that's also not good. So my goal then is to work with the family and the patient, importantly, to make sure that it can bring it down to a more practical, achievable level. Now, there are patients I have seen there are endocrinologists in the room where I struggle hard to bring it down to 300, 400. And then I look at the family, they may have a high risk of dyslipidemia or abnormalities in the lipid metabolism. So I have a different way of looking at those patients in my perspective. Some of them, I might start them on medicines to bring it down. or I work with a cardiologist or a lipidologist, so one who specializes in fat metabolism disorders, dyslipidemia and make it better. I was careful, I thought for a second, because fat metabolism is a different disease metabolically, completely, but that's not an ideal term to use, but yeah. Did I answer your question? Sort of.
Kind of.
So I think my point is that you have to be careful with what endpoint you look at, and it's relative, but you also don't want things to get worse. That's all. If things go north instead of south, that's not good. So you want to be even or getting down. So, yeah.
Amazing. Thank you very much. Let's give a round of applause for Dr. Krishna here.